My name is Shannon Merritt. I am a family nurse practitioner at First Choice Primary Care in Warner Robins, Georgia. I hold a doctorate in nursing practice from Georgia College, and I am adjunct clinical faculty at Georgia College. First Choice Primary Care in Warner Robins is a federally qualified health center. We also have primary medical care home status. We serve not only commercial patients, but underinsured and uninsured patients as well. We see between 25 and 35 patients in a day. As an adjunct faculty, the students are sent to me for 8-hour shifts once a semester during each semester of their education. During those visits, they assist my staff and have an opportunity to complete SBIRT with new patients. The process the students use for implementing SBIRT with the patients is they follow after the MA, the medical assistant, has brought the patient back. The MA does her questionnaire that involves rate, frequency, and type of substance abuse. When she is about to leave, when the medical assistant is about to leave the room, based on the answers of the rate, frequency, answers that the patient has given, she will hand them either an audit or a DAST, or both if it fits, and have them fill it out during the time between her leaving and the students going into the room. When the students enter the room, they tally up the score on the audit or DAST, and taped to the wall next to the computer is a little cheat sheet for them to assist them in choosing the proper intervention. The students are taught from the very beginning to do the intervention while they are completing the physical exam on the patient. I have found that the students are less nervous as far as being sitting face to face and being put on the spot having this intervention with the patient, and the patient's more at ease. The students have an opportunity, they're there for 8 hours each semester. Each student has anywhere between 2 and 3 times that they get an opportunity to use the SBIRT. How this works in First Choice is because of the population, the demographics of the population being more underinsured and uninsured, we have many, many new patients every day. And that gives them the opportunity to do the SBIRT with them. First Choice has been able to provide a continuity for the students by flagging the EMR with the patients, with the student's name who got to do the SBIRT on that particular patient. As the new semester begins, my staff and I review the list of students coming back and go through the EMR to create appointments. We ask the patient, and traditionally that has worked out because it's time for a follow-up anyways. This kind of has a dual role for us. Many of our patient population are not always compliant with following up. This gives them an opportunity as a friendly reminder to, 1, show up for a follow-up, but 2, allow the student to have continuity to see what effect their brief intervention from the previous semester with this exact patient has done. The referral to treatment is started by the students during the visit where the SBIRT occurs. Referral to treatment is definitely the biggest barrier to SBIRT. We don't have a lot of options in the Warner Robins area. However, I've taught the students that the net of referral to treatment can't stop locally. You can start there if you don't have a lot of private agencies by using community resources that are available locally while still looking further, we've recently had an opportunity to make arrangements for a patient to go to Valdosta, which is about 2.5 hours away. That allows more opportunity. I believe that students need to experience SBIRT at a minimum between 10 and 15 times through their education in an actual facility with real patients. I think that it allows them to fit SBIRT into their flow. As providers, each of us have our individualized flow of a patient encounter, and it allows them to, the more frequency that they get to do it, it allows them to make their flow that much more successful by the time they graduate. As far as challenges to SBIRT go, the biggest challenge that most providers say they have is time, and I don't have that. I feel as though if you implement it where the patient is filling out your pre-screening prior to, and the students have a solid knowledge of the different types of brief interventions and therapeutic sayings that they can have with the patient, then it flows for any provider. The students that are with me this particular semester of spring of 2016 are the original students. They're the first group that has been with me every semester since they started their program. And since I've implemented SBIRT here at First Choice. These students have seen as many as a range between 22 and 28 in their time with me. I feel as though that's very important because the repetition increases the ease of use for the students when they graduate. Having the students keep in touch with one another after graduation enables the ability, one, for continued collaboration, and two, to know what resources might be available just a short distance down the road if there's not one locally. The students are keeping a reflective log when they leave the site that day, and it's a different assignment for them than other traditional assignments that are expected to be turned in throughout the semester. I require them to turn it in within 24 hours of leaving the center. The important part of SBIRT to me as a faculty is that the student has an immediate understanding of what they should have said differently and don't have time to ponder on it. Sometimes if you give too long for the assignment, they will look up what the right thing to have said was. And that's not the purpose. You don't get that luxury with SBIRT. When you're dealing with a patient that has blood pressure issues or cholesterol issues, future patient education can be added on. When you're hearing for the first time that someone's a cocaine user, you are making the difference of changing their life right at that moment. So you have to have your words and be comfortable with what you're saying at your very first SBIRT. Their emotions are laid out in their reflective papers, and what I have noticed is that in the beginning, they all feel as though they didn't do enough, that they could have done more, that they could save that patient or make them stop. And by the end of their education, when they've come down to the final semester and they're reflecting back on the continuity of seeing patients multiple times and seeing ones that they've had some successes with and others that have been unsuccessful at this time or not ready for change, that they're not defeated. They're positive about the differences. This is where we could go next. When I see him next time, this is what I can do. And even though they're never going to see these patients again because they don't work there, they still leave me with a plan that I can use in the future.